We're going to jump right into our first session. So, yesterday we began with some of our recommendations and had a very, I thought, productive discussion of them. And today we're going to continue with them. And they clump into two big categories. One is consent to whole genome sequencing and to the possible findings and how they will be treated, and the other is oversight of them. So I'm going to, as I did yesterday, read draft recommendations and then ask commission members and anyone in the audience who would like to comment on them. We're less worried about the precise wording at this point than the actual substance of what we want to recommend. So we left off, we did 4 recommendations yesterday, and we're on recommendation 5, and it, as in draft, reads, researchers and clinicians should evaluate and adopt robust and workable consent processes that allow research participants, patients, and others to understand who has access to their genomic sequences and other data that are generated in the course of research, treatment, and consumer-initiated sequencing. Consent processes should ascertain participant preferences at the time the samples are obtained, so that participants might choose whether or not to participate or whether feasible limits on the use of their samples and/or data can be agreed upon.
Just particularly in light of yesterday's discussion, although the first sentence is already a little long, and so the drafting might make it into 2 sentences, I think we need, as it stands now, to put something at the end that would say, and how these data might be used. Because we are referring in that sentence just to access, but I think that it's important that somebody who's consenting know how the data are going to be used. So I think that's important to add.
I'm going to move on to the next recommendation.
Sorry. So I would have one more suggestion, not for the recommendation, but perhaps for the discussion, which is that especially in our recommendation 1, we focus on flexibility in terms of consent and options to submit data based on consent to open access versus not open access. And I think that we should have we should make a point here, if the other commissioners agree, that we should extend this flexibility very clearly to an option not to deposit data into a public database with government-funded research when the purpose of the study and the consent process does not make that feasible. And I think the same recommendation could help guide journal editors, some of whom have policies that only open access sequence data should be acceptable for submission to their journals.
Yeah, I think that is one important part of what needs to be put in the text, because this could be misconstrued, and it won't be, as you see the next recommendations, but it shouldn't be construed as to say that there needs to be a long list of, this is another point that I'm making, but it's a companion, a long list of everything that could possibly be used, because that basically obviates our earlier recommendation of how we want we're recommending that people be able to consent to, as long as they know clearly what they're consenting to some broad uses. And what you're suggesting is they should also be able to say what kind of database that they are consenting to. Okay.
I mean, I just want to point out make sure that the intent of the commission, as you know, at the present time, in terms of genetic testing, for research purposes, there are extensive informed consent forms that have to be read and understood and signed by the individual. Whereas in the clinical testing, basically if the physician deems it necessary that a particular test should be done, that they would, like any other, blood test, they would order it. And there is not as extensive a process of consent, even though there is a simple process of consent. And I just want to make sure that the commission is not recommending, or whether it is or not recommending, that the kinds of extensive consent forms that we use for research be used for clinical testing or not. And I think it is not maybe clear in this recommendation.
Well, the next recommendation, recommendation 6, is, and that, we'll move on to that after Nita's comment, I hope, really specifies what should be in a consent form, and there your comment is very pertinent, because we need to say there what we intend between clinical and research. Now, just the philosophical point, which is a practical point as well here, there's a reason why consent in the clinical setting is made simpler than in the research setting, and that is there's a direct benefit to the patient in that setting, and therefore there's less of a burden put on incidental things that are not harmful to the patient. That said, I think your point is absolutely to the point of recommendation 6, and so we'll get to that in a moment. But first, Nita.
So your response to Raju is helpful. I've been reading 5 and 6 together to try to understand really what the difference between 5 and 6 is. So I'll hold my comment on 6 for a moment. 5, I'm trying to understand exactly what we are asking to be done by this. So this is one of those times where I'm wondering if it is specific enough, and to the extent that the answer is, well, we're more specific in 6 as to what we want for consent procedures. In 5, I'm not sure what we're really asking to be accomplished by this. And so I'd love a little bit more understanding from others as to how they see this both to be different and how they see it to be guiding.
So I think the most helpful thing, because I have a similar question, and I think we can only answer it if we go on to 6, is to go on to 6 and see whether these are genuinely 2 separate recommendations or one long and necessarily detailed recommendation.
So it can be actionable.
So, yeah, so let's go on to 6. 6 says, and you'll see how much more specific it is than 5, the Office for Human Research Protections or another designated central organizing agency should establish clear and consistent guidelines for informed consent forms for research funded by common rule agencies that involves whole genome sequencing. Now notice here it is research, not clinical practice. Informed consent forms should, 1, briefly specify whole genome sequence, briefly describe whole genome sequencing and analysis. 2, clearly state how the data will be used in the present study as completely as possible, state how the data might be used in the future, and explain the degree to which the individual will have control over future data use. 3, define benefits and potential risks as clearly as possible. And 4, state what data might be returned to the individual.
So, as we were discussing at the end of yesterday's session, we've heard over and over again that there's an impending merger between clinical practice and research in this particular area, which does raise the question about, whether the standards for consent to clinical care should begin to look more like the standards of research, if they are indeed going to merge in the way that it is anticipated. So I would like to hear a little more discussion about why that should not happen. Because it seems to me that if the results of these clinical examinations and tests are going to be pooled into the research community's agenda, patients should be made aware of that and made aware of the risks and so on.
Christine?
I think, though, John, that there's a big difference between making people aware that their samples might be used for research and in the context of clinical care where they're giving them for a diagnostic purpose or some clinical purpose, and the extensive rules that regulate research. So I think I would not want to say that all of the rules that govern the conduct of human subjects research that are found in the federal regulations should govern clinical care. That seems excessive to me. But I do agree that people who are giving their specimens for whole genome sequencing in a clinical setting should be made aware that these will be used for research. And that's part of what Dan was saying before about the uses, the possible future uses. It seems to me that's both of those are doable without making them one and the same.
Dan?
In light of that, that seems to me to be a reason to, at least put it as 5A and 5B, if not keep it as 5 and 6, because 5 is very broad. It covers non-federal research. It covers, clinical care as it's described, and we might flesh out a little bit of what those implications might be in terms of making sure that even in clinical settings it includes consent that is informed by the knowledge that these may be used for other sorts of purposes, whereas 6, I think, is very specific to federal research and the, Office for Human Research Protections, et cetera. And so even if we merge them into one, it should be a sort of 5A and 5B to sort of keep that clear.
The fortuitous consequence of that the recommendation to merge is that the first part actually does speak to clinical uses and says that that there ought to ascertain a set of consent with regard to patients in clinical settings, but then it goes on to be more specific in the research setting where there is no direct benefits of patients, the more specific. And I think I get the sense from this group that we want to do both, but we don't want to saddle clinical settings with as extensive a set of requirements. Anita?
I want to speak to a different issue than the question of the merger, so if others have
No.
comments about the merger question, they should
No,
probably
I
go.
think, I
Okay.
think we,
Okay. I just wanted to raise a question about consent having to do with what we are implicitly accepting or recommending with respect to consent and minors. The way federal privacy laws generally treat minors is inconsistent, and I think that we shouldn't assume that there won't be questions about whether or not minors have their own capacity to consent, right to consent, and at what age that consent kicks in. And what I have in mind is that, for example, under our education privacy laws, until age 18, parents have the right to make decisions about the accessibility of children's educational records, sensitive education records. But under our internet children's privacy laws, the parents only have a right until age 13 to bar children from giving out information to website operators. And then under, of course, state mental health laws, it's often at age 14 that children have the right to make their own behavioral health decisions. So I'm puzzling over whether there's any argument at all that youth or children should have the right, coextensive with their parents or instead of their parents, to make certain decisions about the collection and sharing of whole genome sequencing data. And it's just a question. I think, I'm guessing that we were probably assuming that, of course, it's healthcare, parents have a right to decide, but it's not clear to me if we take privacy seriously, that it isn't the case that at age 13 or 14 or 18 or at some point, right, the child's own consent or assent or something like that is an important part of the ethical framework. So I just wanted to throw that out and to see if anybody else was concerned about that set of issues.
Does anyone want to address that issue before we move on to others? I have Raju and Nita on my list of hands that have been raised, but on that particular issue, so I think it's fair to say that we're spending a lot of time as a commission thinking about children with regard to medical countermeasures, which we'll move to later, but we have not spent much time in this particular case, so it's
Concretely, I think
good that
at a
you raised
minimum,
it.
we should, in our discussion of the consent issue, flag this
Right.
question. Yeah.
Right, no, I think you see a lot of nods on that. Christine, did you want to address this
I just
particular?
want to say, I think that this is a place where, perhaps correctly, the rules about children in clinical care and in research are very different. You know, what parents are allowed to agree to in the clinical setting has less restrictions. In the research setting, parents can only agree to certain kinds of research, because only certain kinds of research can be done with children.
Which
So-
we will get to
Yeah.
very complete discussion of when we do medical countermeasures.
So can I say one thing about that?
Please.
In light of recommendation 5 and 6, I would favor not merging them, because I think 5 might be vague, but it has a sort of philosophical basis of, you know, people should be given the information, whether they're in clinical setting, a research setting, a commercial setting, they should be given the information to make a decision about whether or not they want to do this. That's what 5 says to me. 6 says something very specific about what should be written in the forms for federal research. And I would hate to see 5 diluted or misunderstood as being only around what the words in the form ought to be. So I would favor keeping them separate.
Christine, you said something incidentally. Did you mean that? Did you want to modify this to say researchers, clinicians, and commercial repositories
For 5?
for 5?
I think it has it in there somewhere, it's not in the first
Oh, I
sentence.
didn't see
Yeah, I
that.
think it's a little confusing because it,
Oh,
Yeah.
consumer-initiated sequencing.
yeah,
Yeah.
Okay.
I think it's implied.
Yeah, yeah.
Yeah. Raju?
I want to address John's question, if I may go back, and I think, Amy, you addressed it in part. One of the reasons for the excitement about all of these technologies is that we would be able to diagnose disorders that we were not able to diagnose by conventional methodologies or just clinical information alone. And there are a number of examples of that nature. And so that means that these types of technologies would have significant amount of impact in clinical care. And at the same time that we have to recognize that most of the physicians around the country would have 10 or 15 minutes to be able to see each patient and make a decision about how you'd be able to treat them. And clearly the current kinds of consent procedures that are required for research purposes are very extensive, and you need to have either the researcher or a nurse or somebody spend a significant amount of time to inform the individual and be able to get the consent. I think clinically that just would not be possible. So what we might be doing, if you impose the same restrictions or same constraints in both cases, that would stifle, the use of these technologies for clinical purposes. And many people may decide that this is too much of an effort and that therefore we should not do whole genome sequencing, and I would do only gene A or gene B, and that would be, I think, detrimental. So,
And this is why we have both people who are focused philosophically in astute ways and people who know the practice on the ground, because if we're going to get recommendations that both move us forward ethically and clinically and scientifically, we've got to take both into account. I think it's
Isn't, no, I agree. Very quickly, Raju, would you correct me? Isn't part of what we want to accomplish with recommendation 5 to provide an avenue by which clinically collected whole genome sequencing work can be entered into research use, a research database? Presumably, if the clinician, I guess what you're saying is a clinician will be less inclined to allow that transfer to take place if they are bound by this set of recommendations. Presumably, they wouldn't be bound by this set of recommendations if they're collecting the data simply for clinical use, right? For their patient.
So, Jim, it traditionally, as you know, in the past, much of these records were paper-based records, and therefore there wasn't really, entering the information into any transfer databases and so on. As we begin to use more electronic medical records, there is an opportunity to be able to do that, and certainly academic medical centers have begun to accumulate the results. And there are lots of examples where the ability to accumulate those results and analyze them have really provided, very significant benefits. I just give you one example of that. A few years ago, for example, when Vioxx was used, it turned out that the ability to look at the accumulated data would have predicted all of the cardiovascular, side, events that could have been detected. So clearly there's a tremendous amount of use, and there is going to be a possibility here. So I wasn't addressing precisely whether the physician is going to agree to enter the information into a database, but I was even asking the question whether if you impose strict limits, whether the physician would even consider ordering a whole genome sequence-based test and might just say, let me just look at 1 or 2 genes, and that means that you're basically sort of, looking for your keys under the lights. And that's not what we would like to see.
So let me just clarify here that just so nobody is under the misimpression, we're not letting clinicians off the hook. The first recommendation, recommendation 5, has some significant requirements for clinicians to inform patients of how the data that may be used. It's just that recommendation, the next recommendation goes further with regard to purely research-related uses of whole genome sequencing.
Raj is concerned the first may become onerous.
No, I think Raj was okay with the first. He just doesn't want the first to subsume the second for
We could let him talk
clinicians.
for himself.
Yeah, exactly.
Yeah.
What did you mean, Raju?
Well, I'm trying to interpret, right. Yeah.
Anything else
Do
you'd
you,
like to say?
Raj, what would you say with regard to clinicians?
No, actually, I'm thinking about this, throughout this discussion and conversation, and I think that the way that it is currently framed, the recommendation 5, leaves it sufficiently vague in terms of exactly what kinds of, constraints that we have to put on, and that might provide the clinicians adequate amount of leeway to create,
Yeah.
it's much simpler
Yeah.
consent forms, if that's what is required. And whereas 6 would specifically state for research purposes, what the kinds of constraints are.
And we do say workable consent processes here.
I've got to just follow up for clarification. You're a researcher and you would like my genome, okay? Would you advise me to go see my doctor so that he could, with a very brief and much sketchier set of consent processes, enter my data for you, as opposed to you collecting it directly because you would have this more complete requirement?
Jim, as a researcher, I need to go to the IRB to be able to access your information, however it comes through. And if the IRB would figure it out that I'm trying to circumvent the
Yeah.
procedure, I'd be in serious
Yeah.
trouble.
So let me, I think that this is very helpful. I need to, just let me try to do something very formal, but that has, so Christine, you suggested we keep them separate. What I suggest, given that the view that if we totally separate these with numbers, there isn't the flow isn't clear. There's something very simple we can do with these recommendations. We've clumped these recommendations under topics. And consent is the topic of 3 of these. I suggest under topics, we number recommendations 5A, 5B, 5C. That way, they're under the same thematic topic, but they're separate recommendations. And then we have discussions under them. And that will, I think, that works. Now, Nita, who's been very patient.
So, I hate to say anything that might be more specific after what Raju just said, but I worry that with 5A, or whatever we're calling it now, that we are dodging some really important questions that have been brought up throughout the process. So we heard, for example, early on about BioView, which is Vanderbilt's DNA data banking system, where as part of the clinical process, you may have blood samples, whatever's remaining of your blood sample is put into a DNA database, and it's used for research purposes. And the mechanism and that already, as of 2010, had 100,000 samples. There's 500 new samples at least added every day to the system. The mechanism by which it's added is by opt-out rather than by opt-in. And so, I went through the Vanderbilt system a number of times, and each time I went through the system, I didn't even see the form. It's on a computer screen that somebody's actually, going through. When you finally get there, they say, do you want to opt out or opt in? Because I understood what that was, I said, opt out, please. But it's a difficult question, one that we heard quite a bit about, which is, are opt-in or opt-out procedures permissible in this context? And a second issue that we heard a good bit about was reconsent versus consent. And we make mention of that in 6, at least by reference, by saying whether or not how the data might be used in the future, and explain the degree to which the individual will have control over future data use. But given that these are both issues that have been pretty hotly debated in the literature, have come up within our proceedings, I feel like staying silent with respect to them doesn't provide the necessary ethical guidance to some of the most difficult issues that we heard with respect to consent. So I would like for us to actually address those issues and to provide some guidance as to both that we think that they're important issues to consider, but also what we think those issues are, whether at the broad level or not. So in the clinical setting, do we think opt-out is a sufficient basis for consent? Do we think that that actually constitutes consent? Or at the very least advising that those be important issues that are considered, although I would hope we would do more.
Yeah. So let me say something about opt-in and opt-out, because there is a vast literature. I've read it all, I think, and what we say here in this recommendation would have to be supplemented by what we say in the text. But what we say here implies, I think rightly, that whether you have opt-in or opt-out, you have to inform people of what they're opting in or opting out of. So that's what this recommendation, as it's stated, suggests, that it's not, if you have an opt-out proviso, that you have less of an obligation to tell people what they're opting out of. Same thing with opt-in. There's another issue that comes up in the Vandy case, which we don't address implicitly here. And it doesn't, although it's not clear that this is the place to address it, there, we talk about it earlier, which is what Vanderbilt's system, why, one of the reasons they think that the opt-out is justifiable is there's a strong de-identification where they've actually done more than simply de-identify. They've scrambled the WGSs so that it would be particularly hard to re-identify. Not impossible, but hard. Now that's, I think Nita's right, that's something we could discuss in the text with regard to earlier recommendations. It's less significant about consent than about identification. So there's some other things we could get into. But I do think that recommendation 5A, it won't even be 5 now because the other ones will be clumped too, but it will, I think it covers, it basically says, and this is a question of whether you agree, that whether you have opt-in or opt-out, you still have the requirement of explaining to people what they're consenting to.
I agree with that completely, that we under any approach, we would want somebody to be clearly informed of their options. But as you know from the literature, it is characterized as a consent issue, right? Which is whether or not it is meaningful or the same kind of consent to opt out, even when clearly explained your options. And so one of the reasons that Vanderbilt said, is they strongly de-identify it, so they have increased security measures, but they also said it was because the rate at which people entered their data into the database was significantly higher in an opt-out process than an opt-in process. And so it was the utilitarian benefit of actually having far more people have their data in the database. And not because necessarily they clearly understood, right, but because it is more difficult, right, to say I will opt out, and the presumption is that you're in unless you ask to be out. And so I think that does present a separate issue that I would hope that we would address.
I would be I think, and I'm not a utilitarian, and that doesn't mean that consequentialist considerations, non-utilitarians believe by definition that not only consequences count, but consequences count too. Having read that literature and thought about this a lot, I don't see that there's any moral imperative to have an opt-in rather than an opt-out procedure, as long as you inform people clearly about, and don't use it as a way of getting around fully informed consent.
Are we
But
comfortable saying that?
I don't know whether, I'm speaking for myself, not the commission here. What I would not want to see, and what we could say in the text, is the use of opt-out as a way of getting around fully informing people about what they're agreeing to. So, and making it easier or harder to get people to agree to something that's for the public good, as long as they're being asked to consent to it, it's consistent with what we're saying in the report, that we want the public good to be served, to try to find ways in which people are more likely, consistent with informed consent, to do something that's for the public good. Now, people who are purely fearful of these processes and might, say, wait a second, that makes it too easy, and I would worry about that if we were harming people. But, yeah.
The problem is what part
As
of
somebody who did opt out, this might be an irony, because being on record as not being utilitarian, we may have the utilitarian who doesn't like the opt-out position, so, but.
well, I have not
I
claimed to
don't
be
know.
utilitarian,
I know.
but So I'm not as comfortable with just fully informed consent, or no, fully informing somebody and saying that opt-in or opt-out is exactly the same with respect to consent. I think that the evidence shows that people don't fully understand, even when given the information about opt-out, what it actually means. And that because the default rule sets it up so that their information goes into a database, I am concerned about it. So now the irony here, I thought you were going to say, is that as the person who is less concerned about privacy of
Yeah, yeah,
access,
yeah.
right, that's the part that's a little bit ironic, and yet I do think people should have the opportunity to choose. And I don't think that it is as a meaningful of a choice as to whether or not their information flows when it's opt-out as opposed to opt-in. So,
I think that, I mean, I'm not speaking personally now, but just logically, philosophically, you will find that people who have to opt in don't understand fully either. So that logically doesn't tell one way or the other. And it's only, I think, logically, if you think there's some harm in this to people that we need to protect them from by making it harder psychologically for them to agree to it. And since that would suggest other barriers besides the opt-in, opt-out, I think there is, I think it's a logical mistake to think that there's some morally greater barrier to people opting out to them opting in. In this particular case, when there's harm involved, it's a different story. Dan, so.
No, I think, as has been stated, that if it's now going to be 5A, that under 5A, we need to have a pretty robust discussion of several of these overriding issues. So one of these is the opt-in, opt-out question, and I don't know that we're going to achieve consensus in the next 10 minutes on this, but at least we know we need to discuss that. I think the reconsent issue is another one, and then as Raju has suggested and John had raised yesterday, the question of what we mean by consent, a more robust consent in the clinical setting also needs to be discussed. Because it's not as if there isn't already a gradation, Raju, as you know, in the discussion of informed consent for various clinical procedures. What we don't want, I think, is somebody to say this is just a blood test, the way it would be for a CBC, but yet we don't want to go to 20-page consent forms. It may be something that's more like the discussion that ought to take place before doing simple genetic testing, like doing BRCA1 testing or something like that. But we need to have that discussion as well, so that it isn't just the vague recommendation, but something with more teeth, and that should be in the body, I think.
John?
Yeah, I think I'm prepared to sign on to the sort of analysis of opt-in, opt-out that you just offered, Amy, but I want to affirm the importance of the kind of issue that Nita is raising here, because it goes to the question of how complete our analysis of informed consent is going to be. Nita is, noting here that informed consent has to do not just with the amount of information that people receive, it has to do with the quality of the choice that they make. Informed consent has to do with choosing, right? So if we just limit ourselves to the issue of information, we're not going to give a complete analysis of consent. So I do think that we should have a full-blown discussion, giving the staff more homework on this issue of opt-in versus opt-out, the kinds of issues that Dan is raising. I think this is really important.
Yeah. Sure, go ahead. And
I
Barbara's
think
the-
there's something that, I'm not making a recommendation, but I just, information-wise, all of the people in Iceland, there was an effort to try to obtain DNA and to be able to do DNA-based analysis. So in that particular case, essentially the whole population of the country, they only had the opt-out option. And so the default was to allow their DNA to be analyzed unless they specifically ask, say that I don't want to be included, just for information.
Barbara?
I was just going to say that I think that the opt-in and opt-out is really used in a clinical setting for everybody's clinical records for all of them, and we've talked about the uses from that. If we are going to limit it in some way or even discuss limiting it, I would only limit it to the genome kind of studies and maybe say that they're different, but I'm not even sure I want to go there. So I just want to come down
Yeah.
pretty much in favor of discussing it in our discussion, but leaving it open, because I can tell you with electronic medical records, as we've already heard, it's going to be very important to aggregate the most data possible from the most places, and that's what people are really moving toward, to get into big databases. And
Well,
I don't want to see it limited.
We have in the briefing books articles, and there are more if you want, but there's some really good articles that discuss, among other things, the Vanderbilt case, and should all read it, because if it is the case with whether it's Iceland or Vanderbilt, if we recommend against opt-out, we're basically invalidating a whole set of procedures. Now, that doesn't mean we couldn't ensure that whether it's opt-in or opt-out, it's fully informed, it's as fully informed as informed consent can be, which is never fully on these complicated things. It just isn't. And it's real choice, that people aren't pressured in some ways into opting in or opting out. Christine, and then I'm going to move. Anita's next. Thank you.
Thank you. First of all, the Icelandic DNA project was incredibly controversial among bioethicists. It wasn't as if everyone just said, "Oh, that's great," because everybody wants to opt. Everyone's opting.
Yeah.
Anyway, it was controversial. But what I really want to say is, I always think about these questions about what we should do in this context, in the broader context of privacy law and policy. And it's interesting to me that in the European Union, when it comes to all types of sensitive data, opting in is the norm. That's the law. That European Union is held to an opt-in approach. Citizens,
And they're doing so well, too.
right? But it's because that the quality of choice issue is one, but the nature of the data issue is, privacy is seen as a human right. Sensitive data is very important. It's too important to have the business sector have the advantage over the citizen. So in the U.S., we typically do go with opt-out regimes. It makes it easier on the business sector. It makes it more convenient, and it may not be wrong. And in fact, some courts have found that you constitutionally cannot require people to have to opt in. So we have this sort of ideological, philosophical kind of split in the sort of the geopolitical context, but also in the sort of the philosophical context. I totally respect, Amy, your analysis that it doesn't make a difference as long as people are informed about the things. But we do sort of know that as a practical matter, people do tend to go along with things when it's more, you got to opt out. And we also know that the nature of the data does matter. So I'm not opposed to your approach, but I do think we should understand that it's not a trivial, I'm not saying you think it's a trivial issue, but I mean, it's really a huge choice we're making. We as a country are making if we prefer and go with an approach which says that people should be informed, and then we should be informed in an opt-out.
Let me just be clear. I'm not recommending that all schemes be opt-out schemes. I'm simply saying that morally and logically speaking, when it comes to things that are not directly harmful to people, so we're not pushing them into harm, there's no moral or logical difference between opt-in and opt-out.
And what I'm suggesting,
in both
Amy,
cases, you need to inform people about what their choices are, and you need to give them a choice.
But someone might argue that the nature of the information, that certain data, whether it's financially sensitive or medically sensitive or genomically sensitive, is such that that the harm is intrinsic to the nature of the data. And so we're not torturing them, we're not, causing them
Yeah.
pain, but there's something about the nature of the data that calls for perhaps a higher or different approach. That's all I want to say.
Yeah, no, I understand, and I'm not willing to take that step with regard to say that the data is such that it is intrinsically harmful, and therefore we need to put this protective barrier. And I think if we want as a commission to go that route, we better have a deliberation about all of the language of the public good that's being done by whole genome sequencing potentially, and I think would stand behind that from everything, that I know. Okay, I'm going to make a decision to move on to the next recommendation. I'm sure things will come up, but we have 3 more recommendations to go, and I think it's important to get through them. Recommendation 5C, we will call it now, okay? Funders, and it's still under the consent rubric, so we still have opportunities to talk about some of these really important issues. And let me just say, before we go on, that everything that we've discussed here needs to be put, if not in the text of the recommendation, because we want to keep the recommendations reasonably succinct, in the body of our report, so we come to terms with some of these important issues in ways that you can't do just in recommendations. 5C, funders of genomic research should support studies to evaluate proposed frameworks for return of incidental findings and other research results derived from whole genome sequencing, and investigate the related preferences and expectations of the individuals contributing samples and data to genomic research and undergoing genomic sequencing in the context of clinical care or direct to consumer. So this is about incidental findings. Jim, go, and then Nita, go. It doesn't, we have
Right,
time for
okay.
both, so, go.
I'm a little, I want to make sure that the intent of the commission is, again, reflected in this. It seems to me by a recommendation that some other group or set of groups should support studies to evaluate the disposition of incidental findings is to say that we would be comfortable, or that we have, at this early stage of considering this, no guidance from the bioethics perspective. My own kind of thinking on this, and the reason I looked to Nita also, she and I had a telephone conversation about this, and she can, I think she has even sharper issues with this. But I wonder about such things as recommending, at the very least, who we imagine is best positioned from a bioethics point of view to receive incidental findings. For example, is it really the subject and the person that we have, is it really the individual that should receive that? Should we have health workers receive that? Certainly when I have a blood test, Dan, as you suggested, if there's an incidental finding in there, I don't get a phone call or an email from the blood lab. That goes to my clinician. Now, I realize my clinician ordered the study in the first place, but presumably that's a good thing to do anyway because of my inability to interpret what that incidental finding might mean. I offer that as a suggestion, as one way at least to offer an opinion about what we think the route for incidental findings ought to be, about which I think we're silent right now, and I'm a little uncomfortable with that.
Nita.
Thanks, Jim. I think that's a helpful addition. So I talked to Jim about this recommendation as well as a couple of other ones. What's notable about a couple of the recommendations I've spoken to, I think, is that we're taking a much softer position in this report than we have in some other reports in terms of providing, I think, specific guidance. And that can be the right approach for a number of issues, given how each of these issues really could be an independent study. So incidental findings is an enormous debate in the literature right now with respect to genomic information and other types of research that are happening. And it's especially thorny in something like whole genome sequencing, where we simply wouldn't expect necessarily a person who is collecting a whole genome sequence to have the knowledge, expertise, or ability to be able to go through the entire genome and search for things utterly unrelated to their research and be expected or have a duty to return incidental findings. And yet, some people believe otherwise. Some people believe if you take on the data, that you have a duty to search even outside of your expertise, and if you were to come across something that might be incidental, even if it's outside of your area of expertise, that you'd have a duty to report it. Given that there really is this robust debate that is happening on this issue, given that we are taking on whole genome sequencing, and this is one of the most thorniest issues in it, I think we need to provide some more specific guidance, and to the extent that we actually have any value to provide besides that we think somebody else should take a look at it, I'd like for us to do so, to provide some, what is some of the issues at least that we've uncovered with respect to incidental findings as we've gone through the process? What are some of our initial, intuitions about this subject that we think might guide individuals as they do this research?
Good. Christine?
I actually agree with Nita. I think there's been, it is still a very hot topic in the community of people who think about these issues, but there's been several consensus documents and consensus meetings and some guidance that's already out there. And we heard a lot about it from some of our people who gave testimony, including Dr. Knoppers yesterday. There are these bins, there are these, general, and I think adopting one of those as this makes sense to us from an ethical perspective would be a very good thing to do.
Raju?
I think, indeed, there is a very significant amount of debate about this issue. But I think from the Commission's point of view, I think actually it can be distilled into simple things that we have considered in other reports, and we might be able to make a recommendation. And that is that there are some people who argue that incidental findings, unless they're immediately actionable, should not be reported back to the patient or individual. Other people who say that how could any researcher or a physician or a clinician without really complete adequate amount of knowledge be able to make such a decision, and whether the decision should really rest with the individual who is providing the material to be able to do that. And so it's basically, in a way to look at that, is that the supremacy of the investigator or the physician versus the individual. And I think it may be possible to actually come to, based upon the ethical principles that we have been utilizing, to come to a conclusion about that.
John?
I've got a comment about the geography of this particular recommendation. I'm not sure I understand why this goes under the heading of informed consent.
Okay.
I mean,
Let me explain why this should and why all of it shouldn't come under informed consent. So one, right here under consent, there should be a statement by the Commission about why individuals should know what they're consenting to with regard to the return
Right.
of incidental findings. And so that's what this should say. What John is pointing out, and I think the other comments all are focused on, is whether we as a commission will take a stand on what incidental findings should or should not be, there be an obligation on the part of researchers or clinicians to return, and why.
Exactly,
And
yeah.
that isn't
Yeah,
a matter
in other words,
of informed
the
consent.
substantive issue is not an issue of consent.
But there is a place
There is a
here,
part of it, yeah.
and I think implied by 5A and B is a recommendation that individuals be informed as to what incidental findings, what is the scope of incidental findings that will or will not be returned,
I agree.
whether to
Yeah.
them or to a clinician
Yeah,
or a
I just
doctor.
think that it's important to note that it's not just an issue of consent, and that's why I have doubts about whether this entire discussion should take place under the rubric of
Yeah.
consent. Because look, I mean, it's true that people should,
Correct.
get information about all the aspects of the study. This issue, the substantive issue here, really comes into the domain of like research design or whatever you want to call that, just as privacy would, okay? So people should be informed about what to expect during the study, what will be returned. But the substantive issue is not an issue of consent.
May I?
You may.
I think it is entirely an issue of consent. As some people argue that whether or not the incident, whenever you do whole genome sequencing, you're going to find a number of things that would be considered to be incidental. And the question is, what are the circumstances under which you would provide that information back to the individual who provided the DNA sample? And some people argue that the individual should make the decision at the beginning whether they would want to receive such information or whether they do not want to receive such information. If that is the case, then it is purely a consent issue and not anything else.
Could I just respectfully disagree? I think I follow that reasoning, and that's why I think this is in part an issue of consent, okay? But another way to look at this, Raju, is to view it as a question of what obligations fall on the shoulders of researchers. If they have information that's actionable, that's important for a patient's health, one could argue that the pivotal question is, what are their obligations to patients? And that is not reducible to consent.
Dan?
With respect just to the question of whether to return findings to the individual or clinician, I think we have to bear in mind the fact that many of these studies will be long-term studies going on for a long time. The duration of clinician-patient relationships in the United States is getting shorter and shorter, and so that the ideal of being able to return the results to the clinician may not be practicable, even if it's 5 or 10 years down the line. So I think we need to keep those sorts of things in mind.
When we took on the whole genome sequencing, we agreed that of a focus on issues of privacy and the public good. We can decide to broaden it to the issue of the return of incidental findings. But other than consent, which it is an issue of consent we're all agreed to, the actual decisions about what incidental findings should be returned to whom is actually beyond the scope that we had originally said we were going to do in this report, in part because we recognized, as everybody here recognizes, that there are a large number of controversial and important issues that you can't take on in one report without making it more voluminous and lengthy in duration, as well as in length in the physical product than we had set out to do. So I think we should flag this as an unresolved issue beyond the consent issue on obligations of researchers, and because I think most of us, if not all of us, are pretty knowledgeable about the issues out there, but simply our time constraints and the scope of this report, we didn't set out to do that particular issue. Barbara?
And for just that reason, I sort of like leaving the recommendation in and leaving it as vague as it is and saying it needs more study. I don't think we're ready to be more specific about it. I'd hate to see something not here about it at all, but this really suggests that we need more work on
Yeah.
the issue, and I think that's exactly where we are on it.
Although I think it could be reworded, because I think it suggests that the recommendation is more study, as opposed to the recommendation that people be fully informed about what the status of the return of incidental findings is, on being Socratic wisdom being knowing what you don't know at this time, where we can say on the substantive issue of when and what incidental findings should be returned to whom, because there's a big question, as Jim said, as to whether it should be returned to the individual or to a clinician. We propose that, and we can point to some of the consensus studies out there, which are good starting points, but they need to be brought further to more specific conclusions than we're prepared to do in this report. Nelson?
Yeah, and I think a compromise, and, you know, it could actually go into the recommendation, as I think Nita is probably suggesting, continuing the theme of suggesting what another commissioner is thinking without actually asking her. But the other.
We've been pretty good so
No,
far.
no, I think we've been pretty good. But or it could go into some of the supporting text around it. But I think, I was struck by Bartha's comments yesterday, providing the sort of the three stools of scientific and clinical validity, and which are changing over time, as well as actionability, if that's actually a word. I think that's the one that she used. I like this. I thought that was very helpful for me. That particular theme was very useful, because we understand that the science of genomics is constantly changing, and especially some of the multigenic haplotypes that right now we don't understand. We're not smart enough to understand how those work. Discovering rare and rarer alleles that sum together as multigenic haplotypes could in fact be informative. We just haven't collected enough genomes yet to know those sort of things. And so some of the things that right now aren't valid either scientifically or clinically, and therefore aren't actionable, could be in the future. So I think, you know, we get into the real problem of how granular we're going to get if we really attack this issue. But maybe, again, the compromise would be we touch on one of those bins that Bartha mentioned yesterday. I like particularly that one, and that might provide enough of a bridge.
Very brief
Yeah.
illustration. This is just a dance.
But you must
Thank you.
turn your red
Dan's
light.
comment. I think you're right about, you know, there's certain kinds of things that's going to take a long time for understanding. But, you know, a concrete example today, and we have heard something about this yesterday, is that, you know, when you sequence the whole genome, for example, you'd be able to look at the status of ApoE4. And if an individual who's homozygous for this ApoE4 allele would have a 70% chance of developing Alzheimer's by the time they reach particular age. The question is that should you reveal that information to the individual or not? And when Watson had his DNA sequenced, he said you could make all of the information on the available publicly except delete this region of ApoE4. And the people had to respect his wish and delete that information and put the rest of the stuff on the internet. So again, the people debating as to whether, you know, finding out one's ApoE4 status is helpful or not helpful. Some people argue that it is not helpful. Other people publicly argued, no, I'd actually be able to do something about that. The way that I would deal with, you know, lifestyle, or how I would exercise, mental exercises, and so on and so forth, would be completely different.
That's why I've always used that example of early onset Alzheimer's, because there is no agreement among morally astute, reasonable people as to whether they would want it, about whether it's actionable. It's certainly not actionable in any clinical sense at this point, but it may be. So there's enormous amount of research going on. But under the immediately actionable category, which is the only category I think that there's some compelling, you know, argument at this point for return. I mean, there are arguments on both sides on other things. This one is the most wrenching and the most, I think, if you do a case study of focusing on the controversy that exists now, this is the exact right example to use. I'm going to ask Steve, yes?
So I was just thinking about what we mean by actionable, and whenever that word is mentioned, that's, I think, it's a vague term, and you made that more clear when you
Right.
said immediately actionable. So
Yes.
one could argue for the Alzheimer example that the lifestyle adjustments that are marginally helpful are adjustments that we all should make, independent of knowledge of ApoE status. What about all of the pharmacogenomic information that are not immediately actionable, but might pinpoint a variant that could put somebody at risk and at high, very high risk for a terrible side effect from a drug? That's not immediately actionable, but it's potentially important to the person. Immediately actionable might be a tumor-associated
Right.
gene.
And again, this is not directly, I just want to make clear, this is not directly on the subject of privacy, confidentiality, the public
Well-
good. It's a broadening of it. It's fascinating. But I want to say on the,
Put me on your list when you get.
yeah, right, on the early onset Alzheimer's, it is the case, factually speaking, that some people really want that information and would want to act on it, and other people feel it would destroy them to know it, and they'd rather not have it. And so we need to, as a commission, to recognize that there are some cases where the kind of information that exists and the ability to treat it medically, or the inability, really does significantly divide the population of reasonable, not inherently fearful people into different camps. And this, I think, would be warranted. A whole book on this subject is in order. Christine, and then Jim.
I think maybe you've convinced me that we need to focus on consent and recognize the work that's been done and the difficulty with the controversies over what's actionable, what's immediately actionable. But I think the frameworks that have been developed that divide things into, you should offer, you can offer, and you shouldn't offer, those are useful frameworks.
Yeah.
But maybe our recommendation, if it's going to focus on consent, can deal with the question of, is it all up to the person whose data we're collecting? And I think the answer, I guess my view would be, in not every case is that correct. In other words, depending on the circumstances, depending on what you're testing for, research or clinical care, et cetera, and recognizing the various preferences that we know about people have,
Yeah.
and the potential consequences of receiving information, that we should at least recognize that, in some cases, spelling out what will be done is important, but it's not always up to the person who's consenting. They can say, no, I don't want to do it.
Absolutely. Jim?
I'd like to suggest that we do come up with just 2 or 3 foundational we are a bioethics panel. We did say that we wanted to address we are going to be addressing the ethical issues of whole genome sequencing. I think it's fair to say that but the scope of our work is such that this is not a thorough piece. But it seems to me there are a couple fundamental things that would be wrong to pass, not to talk about. One was brought up earlier. I don't think that I don't know how the rest of the commission believes, but I do think there's a concern that we haven't talked about yet, and maybe we talked about briefly, that I think is a principle that says the discovery of such findings is not the burden of the researcher. We don't expect the researcher to go looking for things. I have a concern that if my genome had been sequenced and at 75 I'm discovered, or 65 to have Alzheimer's owing to being homozygous for ApoE4, that I could go to your database and say, you should have known this. I think one principle is we don't expect that to be a burden of the researcher. I think another principle is that, however, that it's, in my own view, it's wrong not to report the availability of this discovery when it's discovered incidentally. I think of,
So let me just, I want to make sure, I want you to keep going, but it's not a burden of the researcher is number one.
You folks can probably say it better than I, but. I
And
think
what's
that's important.
and number two
One- no,
is?
Number two is that the availability of an incidental finding, it seems to me, it is ethical to report, not what the finding is. In other words,
An actionable one?
exactly right. You tip it off so the individual can make that decision of, just like Watson, of whether or not he wants to know what it is.
Well,
And that's
I don't
why it's on the
understand.
table.
I'm really trying to my job is just
they're
understand what that means.
There are two sides of the same coin. One is that if I'm the researcher, I don't have to go teasing through everything. I don't have an assumed burden to look for all the possible things that I could discover that are incidental to my study. And the second is, if in doing my study, I incidentally discover something, do I have, maybe I should ask it this way rather than having already voiced my opinion, do I have an obligation to let the individual know that the results of that discovery are available? There are two sides of the,
Just
See,
quickly, from a clinical point of view, that's got to be prospective and really can't be retrospective without already letting the person know what the result is. We're calling you up to say, we
Okay,
have a result here.
okay.
Would you want to know?
exactly, our neuro, well, that's why I wanted to debate. I don't
Nina,
think it's quite
but
no,
that-
no, let me give you an
Okay,
example. Our neuroimaging folks your neuroimaging folks are doing some work, and they discover an anomaly. And I wonder if they don't have an obligation in that process. They were actually looking for blood flow studies. They were doing, doing some sort of cognitive study in the brain, but they discover an anomaly. Do they have a responsibility to say, we have discovered an anomaly, and for you to say, well, tell me what it is, or not? Is it a tumor? Is it a structural anomaly? Is it, do you see the?
Yeah, so, especially in neuroimaging, this has come up quite a bit. And the problem is many, but one major problem in this area is many times the person who's doing the research in neuroimaging is a technician who's very limited in their knowledge about other types of things. What they might see is something that might be clinically relevant. And so how some of them have dealt with it is through the process of consent, which is they've included, you can include your physician's information as part of your, signing up a consent process. And you can say, if there is something that may be clinically relevant, I would like it or I would not like it disclosed to my physician. It's then sent to your physician, and then, your physician can notify you if it is something clinically relevant. But the problem of putting, so the obligation then is part of the consent process. And the obligation then is not to go searching for anything. It's only if you come across something that you may know, but it doesn't put a greater burden on the researcher to actually know what that means.
Oh, exactly. That actually was linked to my earlier comment that I wondered about returning data directly to the individual as opposed to a clinician. Yes.
Roger.
There is a very practical aspect that we're not considering, and that is the following. At the present time, no research data on genome sequencing can be reported back to the individual because most of those things are not done in a CLIA lab. Absolutely not. They cannot be done. The only way that the clinical results can be reported, or results can be reported back to the individual, is if the test is done in a CLIA lab. Unless we change, the law changes, that is the way it is today. So when you talk about reporting incidental results, it is only relevant for clinical purposes. And that is when the test would be done in a CLIA lab and the results would be obtained, and you got to think about, returning the results back to the individual. So I just wanted to make sure that when we don't mix up
Yes.
these two issues.
Yes. Christine, and then I'm moving on, because there's a very practical consideration of time here, so, go ahead.
Well, I was just going to respond to Jim's question, because I think that is what John was referring to before. That's the question of what's the obligation of the person who's obtaining the sample. And that's why the people who've worked on this have divided things into clinically valid, scientifically valid, and actionable as guideposts for how you decide what you should return and what you can return and what you shouldn't return to participants. But it's a huge body of literature, and it's complicated because each of those decisions is value-laden.
Besides a commission on bioethical issues, what other groups should opine on the bioethics of this?
Well,
I'm just very,
There are some significant reports out there, and I think you're absolutely right. A bioethics commission should, but if we're going to get a report out on everything that we've actually spent 4 meetings deliberating about and done on, we're not going to get we ought to be, I think, wise enough to recognize that we're
We
not
can't.
going to be able to thoroughly vet the issue of incidental findings. And I think we can see we have something clear to say about consent. We have something that we can say about the very good consensus documents that are out there on incidental findings and the kinds of distinctions they make, which I think we all agree are important distinctions to make, and we can say a lot more than's in this 5C in the text, but we're not going to have, I think it would be unwise for us to think that we could do in a detailed fashion everything that needs to be done about incidental findings.
I don't think we could do everything, but may I'm happy to go with the consensus of the group. I'm concerned that because this is called incidental findings, we imagine it to be incidental among all of the range of bioethical issues associated with whole genome sequencing, when in fact, I think it's one of the biggest issues.
I agree with you, Jim.
Well, if people want to postpone the report and expand it, we can do that. I know the staff is sighing, but that's,
no.
but it is an important issue. I think a number of us know the literature quite well. And but we can't possibly cover it beyond what's been done in the literature and the reports out there in the time between now and September 17th, when we expect to do, and we won't do justice to it. And if we're going to do it in any thorough way, we need more time to do it.
Very brief about this.
Yeah.
So, Jim, the issue about this incidental findings is that whether revealing such information would harm or whether it would violate any of the ethical principles. The only way to really find out is to actually study and to have adequate number of people enrolled in a study where you'd be able to provide this information or not provide the information and study it. And actually, there are such efforts currently underway. There's a big consortium right now of different investigators from around the country who are studying exactly this issue. And I think the results of that would be available in maybe 2 or 3 years. And I think we'd be able to, come to conclusions more. I don't think we're quite ready to be able to make a recommendation and say we got to go this way or this way.
I'm going to make the decision because of time that we're going to move on to the 2 more recommendations, which are about oversight. And
Can I just ask a question of you, which is, you said it's possible that we could delay if it was important to the commission to take up this issue. Is it worth seeing if that's something the commission would want to do, given that some people think it is one of the most important issues to take on?
I think after this meeting, we can see whether there is, I think that's something that we can just see whether a majority of the members of the commission want to delay the report and expand it considerably, or want to issue this report with the possibility of going back and issuing a separate report on incidental findings in the future, recognizing, I'm just being very practical, if we do delay this report, it means that we will also delay the neuroimaging report. There are only so many of us, and so we will we'll move on to medical countermeasures for children and get that out at the end of the year, and we'll just postpone the issuing of this report, which we have the freedom to do, and it will be bigger report. I'm willing, more than willing, I'm happy to go with the sense of the commission. I would say that, given the culture we live in, shorter reports get read more. They just get digested. So my own bias would be to get this report out, say something about what we do and don't know about incidental findings, and then reserve to us the possibility of coming back and doing a report on incidental findings. But I'm happy to go either way.
Yeah, it actually may be the case that since the issues overlap, this issue of incidental findings overlaps with neuroimaging, that it could be something we take up in greater detail when we do report on neuroimaging.
But-
Yeah.
Yeah, let's move on to this, so we get through, and then we can just decide on that. It has been, by the way, in every report, just so for everyone to know, in every report we've done, we've had to decide where we draw the line between what we will feel that we have the time and the capacity to opine on and it's no different in this regard. Recommendation 8. Funders, this is on oversight now. Funders of genomic research and relevant clinical entities should facilitate explicit exchange of information between genomic researchers and clinicians while maintaining data protection safeguards so that genomic and health data can be shared to advance genomic medicine. We had a significant discussion of this and presenters on how important this is. Does anyone want to say anything about this recommendation? I think this recommendation we agree with and need to put we have a lot of supporting evidence. Nelson?
Yeah, I don't feel strongly about this, but I wonder if we should also include the commercial sector here, or not.
Yes. I think that's a good idea. Anyone disagree with that?
I don't think you can force the commercial entities to introduce.
Saying
it.
facilitate.
You
Yeah.
can't force
You don't
anybody.
force.
We're an advisory
We have the
board.
text here. Says facilitate.
Moral authority
All
only.
right. Okay. Recommendation 9. Policymakers should avoid restrictive rules that proffer few benefits and hinder progress in genomic research. This is our regulatory parsimony, which, while it sounds like whatever the contemporary equivalent to motherhood and apple pie, it, I think, doesn't go without saying, given how regulatory rules have expanded. Second sentence, further, policymakers should accommodate ample opportunities for the exploration of alternative models of the relationship between those enrolled in research and the researcher, including participatory models. Open for discussion. We're okay on that? I have one other possible recommendation that I want to suggest that we don't have a draft of, and I don't have, but if anyone has any more on this, I'm happy. I think we've had a thorough discussion of this, but Raju, go ahead.
I just want to make a comment, and that is that during all of this period of time when human subjects or materials from human subjects have been used for research, it's always considered that, the individual who is providing the materials or information is like a donor of information, and that, there is this other group, that is going to take that information and they know better how to, use that information. I think one of the things that's emerging, and I think that we had several witnesses who really dealt with this issue, and say that we should be thinking more as a partnership between the investigators and the participants, and that type of a participatory model, it's truly participatory model and partnership model, that many of these types of issues that we talked about, might be well resolved. And I don't know whether the commission would agree with such a view, and if it is, whether we should try to encourage, such, to move towards such a model where there is a partnership between the patients and the investigators, rather than a passive role that the patients currently have.
Let me comment on that. Raju, I agree with you very strongly, actually. It gets back also to possibility for us to be a little more precise in language. I agree with you that I think donors, donating tissue, donating whatever it is, also donate and give up certain rights of exercise over that. In fact, the same is true in fundraising, right? If you're a donor, you can't get your IRS tax exemption if you continue to exercise authority over the use of those. Partnership implies the other, that there is some continuing connection. And I don't know how, one of the things, I don't know how, if the item we're talking about is the whole genome, you can truly be just a donor. Because the difficulty of separating your identity from it is extraordinary relative to other sorts of things. So I think it would be very good language to use, or very good thought process to understand that there is this ongoing relationship between the individual and the material that has been given for study that is different from a donation.
A lot of the literature has talked about, with the participatory more collaborative relationships, where there's a back and forth, which is partnerships have a kind of legal meaning, which are not strictly speaking true in any particular case, both in the sense that the researcher isn't a partner to the person, and the person isn't a partner in all the research, but there is, in the participatory models, and we've heard some of them in earlier sessions, there's an ongoing collaborative relationship, and that's what this recommendation, which once we flesh out in the text, is meant as Raju, I think. It has many benefits.
Your participant is a
to
good
it.
word.
Participant,
I like that
yeah.
better than partner.
Yeah, yeah.
So participant versus a
Yeah.
donor.
So let me suggest another possible recommendation, which in some sense provides, I think, a nice set of bookends to this study, because we begin the study by saying it is really important to tackle issues of confidentiality, privacy, control with regard to whole genome sequencing, because there's a real public good to be gotten there from the science being able to move forward on it. And a whole set of our recommendations are about protections of confidentiality, privacy, consent, and so on. It would be nice, I think, to have a final recommendation that encouraged the federal government to facilitate access to the social benefits of whole genome sequencing to the broadest possible number of individuals who could benefit from it. Because that, in a sense, makes good in our recommendations the promise that there is public benefit here, and that's why we want to ensure privacy-informed consent to enable this to happen. That's why we want regulatory parsimony and so on. There's another reason to have such a recommendation of the federal government facilitating the broadest feasible public use of the results. The federal government funded whole genome sequencing. We have now an Affordable Care Act, which has been deemed constitutional, and there will be ongoing regulatory policy decisions made as to who has access to what forms of medical treatment and clinical practice. So I think it would be good for us in a broad way, but with clear ethical grounding, because this was funded by the government. It also, and it promises public good, to recommend that the federal government do what is in its power to facilitate access to the goods of whole genome sequencing. Dan?
I'd very much support that. I think it reflects our final principle of justice in terms of those, and we ought to make sure that we make reference in the recommendation to that principle of justice in the distribution, which I think you're implying, but
Yes.
make it explicit. So.
Yes, it refers back to our principles of justice, to public beneficence, and also, frankly, to reciprocity. If the government funds something in the public good, it ought to carry through and, to the extent possible, ensure that it can be delivered on the public good. I know, Steve, you had something you wanted to.
Yes, some of this is reviewed in one of our handouts by Burchard and Bustamante, but in the most recent Whole Genome Association era,
Yeah.
I think that the overwhelming numbers of studies and samples utilized on the research side were from individuals of European descent, and obviously because of differences in the genetic architecture of non-Europeans compared with Europeans, this means that the benefits of that research will not translate into clinical benefits as quickly for non-Europeans. And we should have a recommendation that helps ensure that this is less likely to happen in the whole genome sequencing era.
Good. And that's a way of, in the text, being specific about why this recommendation actually has some bite. There are some specific issues about who can benefit here, and government can make a difference. I have Anita and John on my list.
Amy, I think you're absolutely right that we need this recommendation, and I think it's right that we need it both because it's a matter of justice for all and also a matter of reciprocity. I mean, the American taxpayers paid for a substantial part of the Human Genome Project and deserve the benefits. I had the pleasure of being part of the National Advisory Committee for Human Genome Research back in the 1990s, headed by Dr. Francis Collins, and there was a continual refrain: this is for the public benefit. This is about improving Americans' health care. So, I endorse your suggestion.
Great. John?
My previous comment is now redundant. I agree with everything that's been said. And I think we should also link this up with our synthetic biology report, where we do make a very similar recommendation.
Good. Good. Raju?
I'm also supportive of this, but I also wanted to say that, in 2001, when the draft human genome sequence was completed, it was estimated that it cost about $2.5 billion. And the NIH put out an RFA to say that we would like to encourage technologies to sequence the human genome for $100,000. And several years later, they said that we would support research to make it $10,000 and so on. And that investment that the federal government has put in has not only brought down the costs of this, but there is also a very significant amount of return on that investment, both in terms of investment from the private enterprise, as well as all the health benefits that we're talking about. And so I think that there may be an opportunity here within the context of this recommendation to point out that the great amount of benefit that was derived, and to encourage the federal government to continue to support both the technology and research in this area.
Yeah. No, I think that is a very good prologue to the recommendation, the prescriptive part of the recommendation moving forward, because as you know, we're entering an era that's been characterized as an era of personalized medicine, and it's really important that not only people of means have access to that, and as discoveries are coming, there is the real possibility of providing broader access. But as Steve points out, there has to be the databases to underwrite the validity of the the science and medicine to deliver it to all populations in this country and then around the world. And if it won't happen just automatically, or it will happen more slowly than it should if we just leave it to its own devices. So I think Raju has it's the perfect preface to our recommendation, is to remind people of how much the federal investment has actually paid off to date. And now, looking forward, we see vast potential, and we want to make sure that the potential is for everybody who can benefit, not only those who have the means privately to do so. Good. I think with very few exceptions, we are ready to move forward. We will caucus and just figure out whether we want to expand and delay, or conclude and point to a future possible report. But other than that, and a lot of more work in drafting the text, which we will review and help staff, but we've had a great set of meetings. I would just ask, is there anybody in the audience who would like to make a comment or ask a question? We do have five minutes, and we have something here. Great. And Jim, why don't you read them, because I've been talking a lot.
I'm happy to do it. Are you doing okay? Actually, these are from Dr. Ed Gabriel again. I think actually, Dr. Gabriel, if I may, his first one is about confusion regarding informed consent in the clinical healthcare versus research. And I think Raju helped straighten out the commission on the fact that these are they're entirely different levels of robustness that we need to keep into account there. So that was a comment. Second one, OHARP is not in charge of human research nationally. Let me go to the ones I understand, and I may ask you to stand up on that one. What is the impact of what we're doing on already existing repositories? That's a question we haven't talked about, and he gives as an example military tissue samples at what was formerly the AFIP. What do we imagine the impact of this is going to be on existing databases? Nita?
So a lot of the consent issues could have implications for existing databases, particularly if one of the things that emerge from this is a requirement of reconsent for new processes. But it really, it will ultimately depend on how any sort of legislative response would be structured, because a legislative response could grandfather in existing samples, or it could require that if there are new approaches, that it would expand beyond it and require reconsent. Most likely, given that many of the samples are de-identified, except in the military context where they're, maintained with specific regulations with respect to when they can be sampled, generally to match a sample after there's been a loss. In those contexts, because most of them are going to be de-identified, I would assume that any kind of legislative response is going to consider that and not require reconsent or re-identification in order to access all those individuals. So that's an important thing to consider, and I think a valuable thing for us to note in our report.
So it should be
that
noted.
any legislative response should take into consideration existing databases.
Think others agree with that?
Yeah.
Thanks, Nita. The final, his final comment is to make sure we are aware of a 5-point donor process that is used by Navy Medical Research. And I am not. Could you give us 15 seconds on what that is, sir?
As we instituted in the informed consent process, when there was a donor of samples, that there was very specific questions that were asked. Are you donating? Do you want it identified? If we do anything in the future, do you want to be notified, et cetera, and so forth, to make sure that those parameters were known as part, not only on the paper, but part of the dialogue between the person doing the consent.
So,
et cetera.
Dr. Gabriel, would you forward to us something, a written, summary of that process, because it would be great for us to cite it?
Sure, happy to.
That would be terrific.
I'd be happy to
Link
do
us
that.
to it somehow, yeah.
Great.
Thank you very much.
So we are going to take a 15-minute break. I want to thank all members of the commission, and we will reconvene at 11 a.m.